everyone. We'll start about now. For those who don't know me, I'm Davy. I'm one of the PGY2s in emergency medicine, and welcome to The Price is Right. So for our first game today, we'll be playing easy as 1, 2, 3. I want you to rank these drugs in order from least expensive to most expensive. So hands up for those who think ketorolac is the least expensive. 1, okay. Those who think Zofran is least expensive? 1. Those who think dilaudid is least expensive? Perfect. No, you guys are doing good so far. All right, between the next two, between ketorolac and Zofran, who thinks the next is the most expensive? So for Zofran? So next most expensive, or least expensive?
Is the microphone working?
The microphone's working.
Can you hear me?
Oh.
Just gotta yell.
Try.
Put on your phone.
Is this for you, or is that?
Oh, it's being recorded.
Okay.
Is there a mic on the podium?
There is. I'll try. There you go. That was supposed to play. Okay. So, between the next two drugs, between Zofran and ketorolac, who think ketorolac is less expensive than Zofran? Okay. All right. So ketorolac is actually less expensive, and it's $1.89 for 30 milligrams IV or IM. And then finally, Zofran is about $3 for 8 milligrams IV. So, in thinking of these grand rounds, the purpose was to enhance your education and to provide you with knowledge that will impact your clinical practice. Ultimately, we decided on, healthcare providers, their cost awareness is not too great, especially when you look at the evidence and literature. So our plan today is to, as follows. First, look at the overall health expenditures and what health expenditures are like in emergency medicine. Next, we'll look at what cost awareness is like among emergency physicians and physicians in general, and what the implications of that are. And then finally, we're going to try to come up with a strategy as to how to improve our cost awareness and improve our utilization of resources. So, when you think of costs, there are 3 kind of types of people that react to this. And the first type are those who jump with joy. And as you can see, this is Dr. Scott Anderson. I'd like to highlight these 2 people right here who are looking onwards. The next type is those who buckle down and are ready to follow along. And then the majority of us who just have a tough time following. So before going any further, I'm going to describe what a basic definition of costs and how we classify them. When you look at any organizations, you find 2 types of costs, and those include fixed costs as well as variable costs. Fixed costs do not change with increased utilization or volume, whereas if you look at variable costs, they actually respond directly and proportionally to the volume and utilization. An example of fixed costs could be salaried labor or equipment such as our ultrasound machines. When you look at variable costs, things like medications or suture kits are variable costs. So for my next slide, I'm going to pick on Brad. So you start your shift at 4 a.m. at Vic, and your first patient of the day is an 84-year-old female with a 1-hour history of epigastric pain that awoke her from sleep. It's non-radiating, she's a bit nauseous, and she vomited once. And she tells you that she's uncertain if it's exertional. There's no history of similar. Her past medical history is as follows, and her exam shows that her vitals are really unremarkable. Cardiovascular and lung exam are normal, and her abdo, just a bit of epigastric tenderness. Tell me about your differential.
So for this lady, 84-year-old, she has some vascular risk factors. So we always worry about like AAA would be a possibility. So that'd be one thing that I always want to worry about. But kind of with epigastric pain, so I was fairly bad. You always have to worry about like casting it out. I have go anyways at my point. So cardiac as well. Then maybe she's having an MI that's keep very straight. It's not exertional over the past history, but has some vascular risk factors as well. Other like GI causes gastritis, maybe she has like pancreatitis. She could have like small bowel obstruction. It's basically could be almost anything that happened in the abdomen as well. So
Fair enough. So you actually did quite well. So I classified them according to systems. So thinking cardiovascular, ACS, AAA, looking at GI, a variety of causes as well. And then finally a bit of metabolic, could be things like DKA, for example. Can you tell me about your initial workup? And here's the kicker. For every test you want to order, you got to tell me what it costs.
wow.
You're in debt?
So for AAA, like I'd probably do like I'd use like ultrasound, like extreme focus skills, and try and see if there's anything wrong there.
That's a freebie. I'll give you that one.
So yeah, I guess I have no idea. I am free. I guess.
All right. I'll help you out. So this is kind of a sampling of tests you can possibly order. Do you want to give it a shot?
How much they cost?
Go for it.
CDC, I'll say $5.
Close.
I'll go $5 again.
What else would you like to order?
Oh, okay. What else would I like to order? I'll probably go, electrolytes, uric acid.
Okay.
Wow. I'd probably also use ECG. CK and stroke are not incredibly convinced, but I'll do it because I'm scared. I'll do ACA with GT like it is. So they'll do the blood test.
Are you going to do a blood test as well? No? Okay. Anything else? Okay. Show of hands, who's surprised by these costs? And did anybody actually have an idea of costs already, aside from Dr. Duflo? No? So does it matter that we're terrible at estimating the cost of care? I guess in an environment of fiscal restraints and clawbacks now, it's hard to swallow the evident knowledge gap that we as physicians have of the common diagnostics and therapeutics we use. As physicians, we order tests, diagnostics, procedures, and those generate a lot of the healthcare costs of the healthcare system. In fact, ASAP, an American College of Emergency Physicians, estimated that the healthcare expenditures, the proportion of healthcare expenditures that are related to emergency care, were upwards of 2%. However, a more rigorous trial following that, that was more, I would say, less biased, estimated those costs to be about 5% of national healthcare expenditures. So, today, again, so our overall plan is to look at healthcare expenditures. I'll start by giving you an overall picture. The Canadian Institute of Health Information estimated overall healthcare costs to be around $215 billion in 2014. That was estimated to be about 11% of the GDP. Ranking among OECD countries, we actually did slightly more than average in that. The OECD average is around 9%. When we compare per capita spending, we spend around $6,000 per head. And in comparison to the OECD average of $4,500, we're slightly above average as well. As you can see, the overall trends have been generally an increase. However, since 2010, costs have been slowing down. But what about the emergency department? What have our costs been like? The Canadian Institute of Health Information also published a technical report on health hospital cost drivers. And they talked about utilization and costs associated with emergency care. What they found was that overall, when looking at trends, the number of ED visits per capita did actually not increase over time. And you can clearly see that when you compare the two. However, when comparing the cost per visit, we do see an increase. And although it's not huge, I would say, if you compare the volume, that number quickly adds up. And we were left with the question as to why. What's contributing to increased costs of emergency care? Why have we gone from 4% to 5% of hospital expenditures? Most commonly, physicians will cite medical legal motivations. The crux of the defensive medicine argument is that we order tests, procedures, and treatments to insulate ourselves from medical legal risk. This effect is hard to estimate and quantify, and is even variable based on personal tolerance risk. However, I'd argue that a good proportion of the tests that we order are, so to say, to cover our ass. The next is what I call the purists. And there's a quote I'd like to read to you. I think it's described best by actually a physician called Norman Levinsky, who was a Boston-based physician. And he said, "When practicing medicine, doctors cannot serve two masters. It is to the advantage of both of our society and of the individuals it comprises that physicians retain their historic single-mindedness. The doctor's master must be the patient." Unfortunately, in the context of modern medicine, where we have more expensive tools and more variety of tools to use, especially in a teaching hospital, it's easy to forget our roles as resource managers and order or over test and resulting in overspending. Cost be damned, anything for my patient, right? The next big contributor I call lack of experience. And whether it's the PGY1 in whatever service starting on their first few nights of call, or the newly minted Royal College resident, lack of experience, fear of making mistakes, and trying to avoid potential harm to patients can drive us to over-test and over-treat. This results in significant overspending. But the effect is not limited to residents and physicians. Undifferentiated patients pose a huge challenge to frontline staff, such as nurses, who have to rely based on directives and clinical pathways to work up this patient in order to expedite care. So in terms of those pathways, they're generally more conservative and result in a lot of over-testing and overspending. However, there have been factors that have been protective or reduced costs. In the last few decades, we've seen a lot of the rise of evidence-based medicine and a tremendous amount of guidelines and their development. And those help us direct clinical care. They reduce costs in two ways. One, they give us some medical legal protection in that we are not really driven to over-test when a test is not indicated. And then the second is that they actually reduce the variation by giving us a standard of care so that we know what the most cost-effective method is to work up a patient with such disease. And then finally, cost awareness plays a role in the increasing cost of care. Previously, strategies to improve cost effectiveness in the emergency department have been decision rules, audits with feedback, and educational programs. Cost awareness, another strategy, although be the less sexy topic nowadays, has taken a backseat. However, it can also help reduce the cost of emergency care in the right circumstances. Ines et al. Actually described these circumstances, and they state that in order for cost awareness to be effective at reducing the cost of care, there must be a poor baseline understanding of costs, and physicians must generally underestimate costs. That improving cost awareness will reduce utilization, and reduced utilization should not affect patient outcomes. Today, I'll make the case that the right conditions are in place to improve cost awareness and show governments and society as a whole that we are in good faith examining our own practices to ensure the future sustainability of healthcare. So let's take a break. I know that was a lot.
Can you go back to the last slide with the one more?
Yep.
So the biggest driver there, you're claiming, is medical legal concerns.
I haven't quantified it. I'm saying all of them contribute. I don't think there's any literature out there that tells you how much each would contribute.
And I think physicians in general are very medical legally minded. Although I'm sure there's probably not one person in this room who's been successfully sued, and very few people have even been threatened with a lawsuit. So I think this irrational fear drives it. And another thing I would put up there is patient expectations. I think there is, like nowadays, people come in with these expectations that they're going to get a CAT scan or they're going to get an ultrasound. And sometimes, depending on how busy you are, you can sit down and have a 15-minute conversation telling them why that's not indicated, and sometimes you're successful in talking them out of it, and other times you're busy and you just don't have the time to engage in those kind of conversations, and you just order the test because there seems to be no downside to ordering the test from a personal point of view, but patients will complain and it'll generate, not doing tests generates more problems for the physician than sometimes doing them.
And to address your first point, if you actually do look at the literature, and there has been no precedent ever of, or any basis for the medical legal argument, if you actually look at the Texas experience where they actually put a cap on the amount the physician can be sued for, that actually resulted in more spending. It didn't actually reduce spending overall in healthcare. So, not necessarily a valid argument, but it is argument that I think drives us to spend more, over-test, over-treat, and increase costs. So let's take a mental break, because I know that was a lot. For a CT thorax abdo-pelvis, I want you to name that price. Hands up for those who think it's an A, between $1 and $150. B. Okay. C. And D. The answer is C. I think the majority of you guys got it, so the talk must be worth it. So, moving onwards, I wanted to kind of address cost awareness and its impact on resource utilization and the quality of care that we provide. Before talking about cost awareness, though, it's important to understand what the definition of accuracy is. Accuracy is a measure of how close we are to the true value, whereas precision is how consistently we get the same value. Looking at this kind of dartboard, in this instance, we are neither accurate nor precise because we are all over the place. It's almost as if we've been drinking. Looking at this next dartboard, we are precise in that we are getting consistent measurements, but we are far from the true value. Looking at the final dartboard, we are precise and we are accurate in this instance because we are getting consistent measurements and we are close to the true value. I alluded to the fact that physicians' cost awareness is actually quite poor earlier, but how bad is it? Alan et al. Actually looked at physician knowledge of drug costs, and they searched multiple databases. They included articles where doctors or residents were involved, attendings or residents were involved. The cost of pharmaceuticals were estimated, and there had to be a clear description of accuracy. They ended up including 24 trials, most notably Ines et al., who was from Vancouver. While the studies were too diverse to pool meta-analytically, what they found was the estimation accuracy was generally less than 50%. When they looked at higher quality studies, the median accuracy was actually around 29%. When examining the estimation patterns among physicians, they found that generally doctors would overestimate the costs of cheap drugs, whereas they would underestimate the costs of expensive drugs. The danger here is that while overestimating the cost of something like ibuprofen will not have a great impact on healthcare spending, underestimating the costs of a drug like IV Levaquin can quickly balloon healthcare spending. I also noted that they had this interesting finding or observation that despite substantial and increasing concern about costs, doctors' awareness has not improved in the 26-year span of studies. So I know it's not the sexiest of topics, but I think it's important because it can have a big impact. The same group, well actually let me ask you this. How good do you think we are at estimating non-pharmacologic interventions? Better? Worse? Same?
Worse.
Worse? Okay. Well, the same group actually went on to assess that, and what they found was it was about the same. We actually estimated non-pharmacologic interventions with 33% accuracy, and underestimation was again more frequent than overestimation. The median accuracy was around 27% when they assessed solely high-quality studies. But perhaps emergency physicians are bigger picture type of people. They see the forest and not necessarily the trees of the care that they provide. So Portale et al. Actually looked at and conducted a cross-sectional study or survey of physicians' ability to estimate the total costs of care for patients that they had just discharged. And what they found was that although it was a small sample of 44 physicians they surveyed, physicians underestimated the actual cost or charges 93% of the time, and that the median estimate was actually 36% of the actual total charge, which represents a median underestimation of approximately $1,200. So it's clearly evident that we see neither the forest nor the trees. Anybody have any questions at this point? So hopefully I've made the argument to you that we do have poor baseline cost awareness, and we generally underestimate costs. Let's take another quick mental break because I know this can be heavy. Let's play the bargain game. So I'm going to propose to you two prices for two different tests. I want you to pick the better bargain. I've given you, obviously these prices are lower than the actual prices, you just got to pick the better bargain. So how many would take the ultrasound abdo-pelvis?
Point of care or formal?
Formal. Okay, Matt. All right, how many think the better bargain is actually the CT head? It's non-contrast, simple, without interpretation fees either. Okay. So for the ultrasound abdo-pelvis, the actual cost is $174, giving you a bargain of $49. For the CT head, the actual cost is $209, giving you a bargain of $44. Now, you would. So moving on, does improved cost awareness actually lead to decreased utilization? And I think when we look at the literature, we see that the first study by Schilling, who's an emergency physician in Sweden, he actually conducted a small prospective observational trial, and that looked at the impact of price lists on the laboratory and radiology costs in their emergency department. Their physical organization actually lended itself quite well to this, in that the medicine-based patients were actually cared for by internists in the emergency department, and these physicians had price lists, whereas the orthopedic patients, which were the control group, were cared for by orthopedists, and these physicians did not have price lists. What they found was that in terms of the cost of radiology for medicine patients, the decreased costs were around 20.5%, whereas compared to the orthopedic patients who had, or the physicians that had no price lists, radiographs, actually, the cost went up by 5%. When they looked at laboratory costs, orthopedic patients, they actually had a decrease in laboratory costs by about 9%, whereas for the physicians who had price lists for the medicine patients, they saw a decrease of 21%. So obviously, there's an effect of having price lists available on physician ordering. A better actually study that looked at this was by Feldman et al. And essentially he conducted a controlled trial where the impact of giving provider cost data on a physician order entry system akin to HUDA was evaluated on its impact of test utilization patterns. And to note, this is among inpatients, so not necessarily emerge patients. So for this trial, all providers, including physicians and non-physicians, so for example, nursing staff, anybody who would be able to put in an order, were evaluated. The intervention arm included tests that had fees displayed associated with them, whereas the control arm, there were no fees displayed. Here's what they found. First, they had a 9.1% reduction in the number of tests ordered among the intervention arm. When they looked at the costs associated with this, they found a 10% decrease in the cost. This actually, over a 6-month period, amounts to about $400,000. When they actually adjusted for the orders for physicians and patient characteristics, they actually found that the effect remained statistically significant. So there's the second criteria. I think that, or hopefully I've convinced you that with the evidence, improved cost awareness can lead to reduced utilization. As you know, it's time for another game. For the following 3 tests, which one do you think is the most expensive? Hands up for chest PA lateral. Okay, hands up for chest AP portable. Hands up for an abdo series. Okay. So chest PA lateral actually costs you $32. An abdo series is $79. And a chest AP portable is actually $110. These are all without professional fees, so no interpretation. So what? Does it matter that we're overspending if we're still providing high quality care? The evidence actually proves otherwise. There's a study by Fisher et al., which was actually published in 2003. And they actually explored whether regions with high healthcare spending had better health outcomes, most notably mortality. Let me just orient you to this busy slide. Essentially what you'll find is, along here is 4 cohorts of patients, those with hip fractures, colorectal cancer, acute MIs, and this is actually just a general cohort of overcomers. On this side, you have quintiles of health spending, so the lowest being, whether these patients are actually in a region of low healthcare spending compared to these patients with the highest healthcare spending. And what they actually looked at was they observed the mortality for this cohort of patients, and depending on whether they lived in the lowest or the highest quintiles of healthcare spending. What they observed was that in patients with highest healthcare spending, they actually did not fare any better in terms of mortality. And as you can see, most of the tests of significance were actually not statistically significant. When you actually evaluate some of these trends, what you find is actually the mortality actually increased for some of these cohorts as higher healthcare spending occurred. So, what you're telling me is that improving our cost awareness can reduce our utilization and perhaps result in us providing high quality care. Evidence, I think, makes a pretty damn good argument for that. So, these are the criteria that I've mentioned previously, just to review, who are based on cost awareness, generally underestimating costs. We improve cost awareness leading to reduced utilization. Finally, decreased utilization does not adversely affect patient outcomes. Any questions at this point?
Just wondering, what does it cost for a patient to actually register? All these additional costs aside, so a patient presents to emerge, they register, and they're brought.
I unfortunately wasn't able to get that cost. I think that's something that's very valuable and something that should be looked into, because a lot of our population actually, or a good number, register and eventually leave because of wait times, but factoring that cost in would be important.
I think the hospital, I think St. Joe's is urgent care, and what they charge is probably not necessarily what the cost is, but I think it's $500 just to register. That's the hospital cost to the person who goes into urgent care.
That's the hospital charge.
That's hospital charge. You know what the costs are, I don't know. I don't know how much of a profit margin the hospital is looking for.
It depends. If you really got to look at your fixed and variable costs again.
Yeah.
If you add registration clerks, then there's a cost to registering those expectations. If the registration clerks are sitting there, and the triage nurse is sitting there not doing anything else, can't be used to do some other function that they're more needed to do, so you have to add people, then there is a cost. But if you've got the lights on and people are sitting there, then there's effectively no cost to registering somebody.
So I've actually met with Dr. Duclos' associates in the clinical decision support team. And what they described was that the costs were actually calculated based on a top-down fashion. So for, let's say, registration clerks, their budget or their salary is such, and that cost will be kind of distributed based on their functions and how many patients they actually see. And that would be how you would calculate the cost for registration. Any questions otherwise?
Just a quick comment on benchmarking. We do, well, HCC's emergency departments are one of the most expensive emergency departments in the province when we benchmark against other emergencies, and that's not because of boarded patients, because boarded patients are taken out of the equation. We just have an expensive model, and our nursing ratios, sorry to the nurses here, are actually better for the nurses than they are at most emergency departments in the province. So we tend to have a 1 to 3 or 1 to 4, whereas the other emergency departments are around 1 to 4. At the very sort of best ratio. So we have an expensive emergency medicine model from a nursing perspective, even when you take boarded patients out of the issue.
Is that across academic centers where you probably have the same thing?
We're benchmarked against other tertiary care centers with similar volumes outside of Toronto.
Sorry, so is that what is the major driver to us being more expensive, or is it because we order more tests?
No, the major driver is always human resources. 85%-ish of healthcare costs are related to human resources, most of which are nursing and physician.
I guess my question is, how do we translate this stuff into change in physician behavior? Because I think you can tell people till they're blue in the face, like more tests doesn't necessarily mean better outcomes. Your one slide even said with experience. I'm not sure that's true. I think with experience, people develop patterns of this is how I investigate a patient, and then those behaviors become entrenched, as opposed to the more you would think after you've seen 10,000 patients with chest pain, you would get a real sense of the 14-year-old's not having an MI. But that's not necessarily, I think sometimes after 10,000 exposures, people are like, I'm doing it right. I know it. One of these times I'm gonna hit the jackpot. So I don't know if you're gonna talk about that, but how do you've shown very effective information and data. Now how do we change physician behavior?
Oh.
Yeah, go ahead.
I mean, the best way is to standardize. You have to decrease variation in practice to make people comfortable practicing in a new way. So they're practicing the same as their peers, and as a group of 80-some docs, if you agree this is the way we're going to work up X with these criteria, you will over time get people to conform to the mean and decrease the amount of tests that you do. Hence decision rules.
At some point though, like you don't need a doctor then. Like if you're going to standardize everything, you don't need a doctor. I mean, part of it has to be your judgment, your experience, your knowledge, but I do agree in general, like I think you can affect things like ordering DQ scans by having those kind of decisions.
That's where I'm saying that's where you start. You standardize where you can standardize.
There's other things, like there's very low lying fruit, like the difference between, and I don't have the numbers, so hopefully Davy might have them, but the difference between say PO Levaquin and IV Levaquin are enormous, and it's so bioavailable, so you gotta have a really strong reason why you're giving IV Levaquin. So especially that first dose, you know, in the emerge, like those type of things, just by doing that once in the shift, you've like blown your budget.
I like the idea of putting the price in Hugo. You're not telling people you shouldn't order the test, but just making them aware of what the test costs. I mean, you might change your mind. And sometimes there are things where you just tick it off just because it's there, and really you don't really think it's going to make a difference, or it's not even that valuable information. But I do think that letting people know the price, just that alone, will reduce the cost.
I figured with all this discussion, I was hoping Dr. Pringle would be here and that you would be. Let's play a quick game before we proceed. So this is higher or lower. For the cost of ketamine for a 100 milligram vial, is it higher or lower than $8? And higher? Okay. Lower?
It's such a terrible drug, I think we should just not use it, so the cost will go to zero.
$9.03. How about propofol? You use that, right?
That's a good drug. That's a paradise cost. Oh my God, I fell for it.
A 200 milligram vial. How much do you usually spend?
It's
higher than $10?
Lower.
Hands up.
Higher. It's lower.
Hands up for higher. Hands up for lower. $2.50.
There's no reason to use anything else. Rocker on is a good drug too.
So for a 50 milligram vial of rocuronium, is it higher than $15? Hands up. Okay. Lower? $2.73. So, as Dr. Anderson alluded to, we're trying to figure out a strategy as to how to make this all better. I've given you the problem, and I think it's only responsible to suggest some solutions. So, looking at the distribution curve of median cost per visit, we obviously know who's usually down here. However, I would say that overall, physicians tend to be on this side of the curve where we actually overspend and overutilize. Some of the solutions that we were suggesting, in terms of medical legal, a medical legal perspective, there are several ways we can actually mitigate the medical legal motivations. First would be to educate physicians regarding the lack of evidence for defensive medicine, which I alluded to earlier as the Texas experience. And then finally, encouraging more policy statements and position statements that set the standard of care and give us a basis to not order a test. And then finally, we can always rely on guidelines and decision rules that, for example, the Canadian CT head rules or the Ottawa ankle rules. Although those are good evidence, I don't think they're utilized frequently enough. This can actually create an environment where we accept more risk and gives us a basis to accept more risk. When talking about the purists, unfortunately, there isn't much we can do aside from education, and I think that's going to be the most powerful tool. Understanding that testing more doesn't actually result in better health outcomes is important. And sometimes the best thing to do is to do nothing. In addition, earlier exposure, I think, to cost and cost awareness, whether it be in medical school or earlier in residency, is important for residents and trainees as they progress through training. The next would be the lack of experience. And unfortunately, this is something that also will take time. And I know Dr. Anderson alluded to the fact that some people become entrenched in their patterns, but I would hope that with more experience, you become more comfortable and you know how to add value to the patient pathway and remove wastes, such as in TPS and MUDA. Going on, in terms of practice variation, ways that we can reduce practice variation is actually by looking at our own and what we do. Here, these are actually statistics from our own emerge among you physicians. We look at, for example, the percent of ultrasounds ordered, usually, and these are the ranges. So the minimum is 1, the percent is 13 for a maximum, the 25th quintile is 3, and 75th
Davy,
percentile.
just for clarification, you're talking about percent by physician, correct? Percent
Yes.
of patients in whom you order those tests.
Exactly.
Over a quarter.
I just wasn't sure whether it was what we're talking about.
Go ahead.
Over 3 months? Is that-
The first quarter of this fiscal year, April to June, 2015.
You see?
Every third patient CT is ordered.
Yes.
On, by one physician. And, yeah.
I would say the biggest, at least impressive number for me was the consults. So for a physician, 35 max % of consults of the patients they see. It's quite high, although the distribution is not too far from that. So what is the solution?
Question for Adam. On those numbers, is that limited to emergency physicians doing an emergency shift as opposed to somebody might be a trauma team leader and order CT scans on those patients? Is that averaged in?
Emerge patients on an emerge shift. Emerge docs on an emerge shift. This is basically the collective of the physician performance indicator cards that you all received in August and will receive again in a month or so, and the range of it. So I would suggest the most expensive thing on there is that consult rate at the bottom, because when we consult, 90% of the time people are admitted, and that's somewhere where our responsibility as emerge physicians for aborted patients or bed block is. If someone's consulting a third of the time and not seeing sicker patients, because this doesn't correlate to CTAS, because certainly we have variation in that, then we're adding to the aborted patient problem and certainly the cost of the hospital.
Adam, would you not agree, though, that that's not entirely our responsibility? Because if we feel uncomfortable about a given patient, then we're asking for a colleague, say an internist, to assess the patient with their increased level of knowledge and then potentially discharge the patient.
The one thing you can't argue against, though, John, is that kind of, can we go back to that slide? That degree of variability has to give you pause. When you are that discrepant from what your colleagues are doing, that needs to serve as a
I just wanted to be clear that with respect to consults, it's a double-edged. I mean, it's two parties that are responsible.
For sure, and I don't want to sound like I'm two-faced. In this audience, I would stress the variability. In an internal medicine audience, I would stress that 85% of us are between 15 and 20%. And really what should be happening is the internist should be in a merge in the middle of the night, helping make the decision and send the patient home, and that's their responsibility. So I just, last week at rounds and 100 times in the past 6 months have made that very clear that when you're on call, you should be in the hospital, not at home, refusing to be woken up. So don't think that I'm not sort of on our side, so to speak, but just to point out that we do have some work to do in our campus of variability.
And how do we do that work? We work on physician performance indicators.
That's so cheesy.
And then I think it's only fair that I would mention the Choosing Wisely campaign. And basically this campaign, or briefly what it is it started was started by Dr. Howard Brody in the US. And he wanted each specialty society to identify 5 tests or treatments that are overutilized and provide little benefit to patients. CAPE actually accepted this challenge and published these 5 tests or treatments that provide little value to the patients we see. And I guess to push the envelope a bit further, we would actually recommend to Dr. Duclo whether compliance with recommendations like this can actually be incorporated into the physician performance indicator reports. I'm not going to harp on any further, but I do want to take a poll. How many would like to see our ED order entry system go from this to this?
I'm sure the hospital would like that, and they have the power to make it happen. Like, it doesn't make any sense.
I think it's a cheap, quick, simple solution that has potential for big impact.
I didn't know a lot of it's the same as ibuprofen. I have to start ordering more than a lot.
Davey, that's the pharmaceutical cost.
That is the pharmaceutical cost, and for things like this, where you have a maximum of 6 doses, this is the total cost for the 6 doses.
But it's not the nurse back and forth to the bedside with the syringe.
That does not include the IV equipment. That does not include hanging normal saline to run the IV. That is just the drug itself.
Yeah.
So, looking at all these different factors that we've discussed, how do we go? Or actually, what I would like to say is that how do we go from this varied distribution or normal distribution to actually a skewed distribution where we reduce our median cost per visit and actually become more like Dr. Pringle?
That's not a good selling
Post-call is a bit delirious, so
correlate that with the size of his file.
So overall today we've discussed healthcare expenditures and the overall healthcare expenditures. We've also discussed a bit about cost awareness and how that affects resource utilization and the costs of care. I've also hopefully given you a bit of an idea as to, or a few strategies that you can go forward with. However, walking out of here, I think it's only fair that I give you some practical points. I think the first direction forward would be to actually champion price lists and actually try to move forward with adding prices to our ED system. In keeping with TPS, I would recommend that we focus on providing value and reducing or eliminating waste, whether that's reassessing the clinical pathways and the medical directives to make them more cost efficient is something that's important. And then finally, I would urge all staff and residents, I know we're all very, or mostly involved in research, to include a cost component to their research. In this era of emergency medicine, we can no longer ignore cost effectiveness. So I want to thank all of these beautiful people, Dr. Skoretz, Dr. Adam Duclo, Ala, who's been amazing at helping me scour the literature, Dr. Davy, the clinical decision support team, as well as the pharmacy team. Thank you.
That was awesome, Davey, especially like all the pictures. Did you come across anything about patient awareness of costs?
I have not actually. I haven't found, I mean, most of the literature is targeted towards who directs care and who actually orders the test. And that would be the physicians, whether, or actually the providers, whether they be physicians or nursing staff. But not much of the literature actually comments on what patients think.
Ideally, in a perfect world, patients would know how much goes into their emerg visit, and it shouldn't alter the sick people that come in, because they need to come in regardless, but for the walking wounded, I could easily see the family doctor, instead of having $500 tapped on for registration and emerge, it may make things a bit different.
Actually, a couple of points. If you look at the experience in the US, it's markedly different than here in Canada. Because of OHIP, we're very sheltered from costs. Whereas if you look in the US, actually patients can actually have cost calculators to know what the cost of that emergency visit is going to be like when they get the bill. And so I just think the experience is going to be a lot different between the two, but unfortunately I don't have data on that.
Yeah, I think one article, the beginning, the introduction, talked about the cost of healthcare, and I think it quoted something like 15% of personal bankruptcies in the United States are due to healthcare costs. People aren't able to pay the medical bills. So I'm sure they're a little bit more aware of what their costs are when you go to the hospital.
I suspect the best place to incorporate this is medical school. If you start learning about the costs right from the beginning, I bet you'll make better decisions.
There's a couple of residency programs where it's in the States that came out when they talked about where it's starting to be incorporated into it.
Davy, one of the things that continues to amaze me is the number of patients that we bring back to the emergency department the next day for investigations. So, for example, a semi-elective ultrasound that a patient is discharged on Friday evening and brought back on Saturday, so a premium day with regard to OHIP costs, a tech who is staying or having to come in after hours, when a lot of these investigations can be done through the family doctor earlier in the following week. Has there been anything that you've come across that compared utilization through the emergency department in comparison to outpatient testing? Is I think that on the one hand, we're saving money by not bedding these patients down, necessarily holding them for an investigation with regard to bed block and efficiency in the emergency department. But on the other hand, what we're doing is bringing an awful lot of people back, which is my perception if I look back over the last 10 to 15 years, way more people back to the emergency department for more semi-urgent utilization of testing than we ever used to do before.
There has been, and if you recall the cost drivers report that I alluded to in the beginning of this, or that I described in the beginning of my presentation, they actually compared what the cost per visit of the emergency department is as compared to what it would be like to a family doctor. And they actually noted that the family doctor visit would be about 25% of what it would cost to come back to the emerge. So in terms of comparing whether it's good to send a patient home with directions to follow up with their family doc versus to come back to emerge to arrange for their testing, I think there's a huge cost discrepancy there.
Thanks for bringing that up, Karen. Christy and Vico and I have a meeting every Thursday morning at 7:30 in the morning to talk about diagnostic imaging for a number of reasons, and that's one of them. Hence the reason that ultrasound hours have been expanded at Vic over the past 6 months to 11 o'clock at night. Our role in that is diversion, and diverting those patients to another care provider. So bringing back a 40-year-old pain-free for renal colic that's not going to get a lithotripsy for 6 weeks or 4 weeks kind of doesn't make sense to me when we can hopefully get them followed up with a family doctor. Similarly, we're working on setting up a primary care follow-up clinic. So instead of bringing them back to emerge, send them so the people that are unattached or have an unavailable family doctor can go to a primary care follow-up clinic instead of bringing them back to emerge for that test. So I'm very comfortable putting it in the patient's hands to say, you need an ultrasound of your kidneys, go see your family doctor, and documenting that in the chart as opposed to bringing them back. So that's probably 50% of the ultrasounds that we do, but then there's the ones that we bring back that we need to need an emergent test for cholecystitis or appendicitis or low risk ectopic. and hence the expanded ultrasound hours. And we're looking at a couple of strategies. One, sending the Joe's urgent care as opposed to bringing them to the emergency department, so they're scheduled visits as opposed to longer visits than they have in the emergency department, or again, that primary care follow-up clinic that's outside the emergency department, or even a surgical clinic follow-up.
Well, my concern is with the family dogs. A lot of family dogs can't seem to get ultrasound in a timely fashion. So I agree, you know, you don't need to be a follow-up ultrasound tomorrow, but 2 months from now might be.
I think that is a perception that may be the reality for some. But if a family doctor is willing to do the work that we're willing to do to get an ultrasound the next morning and talk to a radiologist like we have to do at 8 o'clock on a Saturday morning, they'll get that ultrasound that week. So we just can't continue. I agree, I think, with Karen saying we can't continue to take responsibility when, although given the recent cuts it's being changed, if you want a family doctor in London, you can have one. So this uncaptured population has some responsibility for themselves.
Just one other comment in respect to that. I think we're a little bit isolated from primary care in what we do in ED. And I think we need to ask the question always when seeing a patient like that is, what would I do with this patient if I were a family doctor and they walked into my office with this complaint today? And if the answer is, I would send them to the emergency department, and they need to have the testing now, like somebody with chest pain, possible ACS, fine. But if the answer is, you know, they've got right upper quadrant pain that's now resolved, and I would send them to the lab and send them for a follow-up ultrasound and bring them back to my office in 2 or 3 weeks' time, then that's the kind of thinking that we can use to say, you know, that patient can go to the family doctor and get that follow-up, even if that ultrasound is going to be 2 or 3 weeks down the road.